Part of the CME criteria, please be aware, this is a CME accredited event. There are no commercial sponsors of this grand rounds. Disclosures were reviewed and no conflicts of interest were found. And this morning, Dr. Stroup will be talking to us about Kenyan health and healthcare initiatives and the urologic experience there as well.
Good morning. I thought on the anniversary of my 10th year of working in Kenya and the recent developments in creating a Yale hands-on training program in Kenya that we would give you a little update on what kind of mischief we've been into the last 10 years and where we're headed. There are no disclosures. The objectives of this talk, to gain a little better understanding of healthcare infrastructure in Kenya, appreciating the challenges of working in developing country, understanding the importance of a Yale Urology program in Kenya. A little bit about Kenyan demographics. Population 43 million, about the size of Texas. 42 tribes, and tribal ethnic differences are very important. Infant mortality is still significantly high. They only spend about 4% of their income on health care with a promise to go up to 7%, but right now the healthcare system is somewhat of a shambles. In terms of what we deal with in this area, primarily food and waterborne illnesses. Malaria is still a huge problem. There is some schistosomiasis. HIV/AIDS we'll talk briefly about, and respiratory issues are still of paramount significance in this area. So in terms of mortality, almost 30% of deaths are still indirectly or directly HIV related. High mortality from TB, malaria. Automobile accidents and violence, unfortunately, also have to be factored into this. The Save the Children Foundation publishes statistics every year, and Kenya still ranks relatively poorly compared to other countries with respect to women's and children's health. This has to do with longevity, mortality, morbidity figures. HIV is slowly getting better. It was about 6.8 when I started there 10 years ago. It's now in the 5.2 to 5.9 range, but there's still enormous numbers of children who are orphaned. Laikipia County is the area where we work, just above the equator. As you can see, there is a poor distribution of healthcare facilities in terms of facility births, HIV, antiretroviral therapy, and that will be slow to change because of the demographics of the country. There are a number of different levels of healthcare infrastructure. Starting at the very bottom, there are 2 teaching hospitals. One is run by Indiana University in Eldoret. The other is run by the government, Kenyatta General Hospital. There are a few provincial hospitals that have CAT scanners and ICUs. Our surgical program is going to be targeted at the Nanyuki District Hospital, about 150 beds. It now is a brand new dialysis unit, and it can perform most basic services. Up at the very top is where I've been working for 10 years at the dispensary level. That's the first contact point for people in need of any health. So Kenyan Healthcare Initiatives is a 501c3, which we formed some years ago, dealing with health, education, and water. We work with community, government, and non-government organizations in order to improve lives. And these are some of the areas that we've been working with. We talked a little bit about some of these stats, but basically life expectancy is still only 57 compared to the United States. Actually, our longevity dropped a little bit in the last year. So in terms of where we work, this is an East African country, as you know, on the Indian Ocean. We drive about 4 hours north of Nairobi, just above the equator, to an area called Laikipia County. Laikipia County is divided up into 4 or 5 sub-counties, and within this area, there are large tribal groups. We work with Maasai almost exclusively, and we work with an incorporated entity recognized by the Kenyan government. They have their own board, population about 9,000. These are typical scenes of the areas where we work. It has had a drought for about the last 4 to 5 years. When it is green, it's not bad. It's typical Manyatta, where many people live. It's highly volcanic, and it's a pastoral society, so they are grazing their herds. Low tech, by and large. The structure is strongly patriarchal. On the far left, senior elders are the ones that make all the major decisions, and they are the ones that are generally elected to the boards. Junior elders are the decision makers. The Morans are in charge of security of their herds. And a lot of the kids, instead of being in school, end up taking care of the herds. Women are obedient, highly structured. There's still a lot of marriage for a bride's price. These are marriages of convenience. But the more education a woman gets, the less likely that is to be the case. If a woman is abused or leaves her husband or becomes a widow, she becomes an outcast, and they often will band together, form their own little areas to support one another. They're really responsible for all of it. Building houses, water, firewood, cooking, milking animals, tending the garden, caring for the children. Now, I'm not going to spend a lot of time with this, but last year we started a project where we've been interviewing women about an hour and a half per person to find out about their day. And their day really is quite amazing and starts early. We have a sewing center that we've created over there, and the women usually can't show up till about 10 o'clock in the morning, and this is part of the reason why. They milk the herds, they do the cooking, they are responsible for firewood, they walk everywhere they go, they walk their kids to school. Kenyan Healthcare Initiatives is a strong believer in collaborative relationships, which has led to some rather amazing outcomes. But starting on the top left, a few years ago, we were approached by a Kenyan nurse who said there are no menstrual supplies anywhere in the area. And so we ultimately found a solution, which is an international organization called Days for Girls. We are the Connecticut chapter under our nonprofit. American Friends of Kenya provides textbooks and teaching aids for 200 schools in Kenya. HOMAC is a prosthetic billing company with which we have a relationship, and we have several young people that have been able to get prosthetics. Yale Urology, Quinnipiac University Global Health, their first second-year medical student just completed her first rotation in one of these communities, working on some exciting things. At the lower level here, we have relationships with county health department, hospitals and clinics. Obviously, we dovetail with the group ranch very closely. And within the community, there are what are called community-based organizations. And we also work with schools. Mukogodo Girls Empowerment, we're going to talk a little bit about dealing with FGM and women's issues. And the Days for Girls Chumvi, which is a sewing center. We've been a strong believer in looking at both grassroots, bottom-up information gathering and top-down discussions. All of the projects that we've worked with over the last 10 years have originated from our partners to us as suggestions and needs. And then the top is a typical community meeting that we've held each time we go over in different communities. And the bottom, these are boards of trustees. There are nurses, physicians, personnel who all have looked at strategic planning issues. We've built a number of clinics. The one on the top left was there before we started. However, we have provided financial support for them for some years. The top right, Locosero, was an empty shell when I first went over, and that was open and providing care. Bottom left is just a typical picture of our supply center, a small pharmacy. The bottom right is a place called Antalabani. This clinic has been built but is not yet open, partly because of security, partly because of its remoteness, and it also needs to get water from a nearby stream. But these folks are currently walking 6 hours to get to the nearest healthcare facility. So that's why this particular location was targeted. Within the community, as I said, we have created a sewing center to train women in how to sew the menstrual kits. We are supporting a program that is strongly in favor of abolishing female genital mutilation. I just wondered, does anybody have any idea what this is and why it's there? I just want to show you how smart these people are. That's an acacia fence with big prickers, and underneath that is a hand-dug trench where a water pipe has been laid for miles and miles and miles. By building that acacia fence, it keeps the elephants from stomping down on the pipe to break the pipe to get water. And these are some schoolgirls who are listening to a Days for Girls presentation. At the county level, this is Dr. David Hill from Quinnipiac. These are all physicians. They all have private practices in order to survive financially, but they all work for the federal government as well. On the left bottom, my spouse, Marianne, who many of you know, one of our board members, Dr. Mayana, who's in charge of all the clinics in the area where we work. This is another gathering that we've had. My daughter-in-law, Carrie, who's a chief resident in OBGYN at Tufts now, who is strongly committed to working in this area. And her hubby and my other son. The government really wants to get people to deliver their babies either in a clinic, if it's an uncomplicated delivery, or in a hospital setting. So we tried to brainstorm with the nurses on how do you create incentives to get women to deliver in the clinic. The midwives are extremely skilled. So we're going to skip the top of them just a second. We purchased for them state-of-the-art fetal Dopplers, which is encouraging the women to get to the clinic so they can listen to the baby's heartbeat. We provided Days for Girls heavy flow kits, shields and liners, receiving blankets, newborn outfits. And then the community women built a structure, which we're going to show you, called a maternal shelter, where the woman can rest if she's in false labor, or she can recuperate after her delivery before she walks home. Here's just a fetal Doppler in use. This is what they were using beforehand. Many of you have probably seen those. Maybe they're in the archives down the hall here. So the women built this maternal shelter that's very similar to the manyatas that many people live in. Inside, it's fully plastered with the dung and straw plaster. It has a bed. It has a small hearth. It has a solar-powered light. And this was so successful in attracting people to come to the clinic to deliver that they've now built a second one of these. There's just a mother resting after her delivery. She'll stay there perhaps for 12 hours or overnight and then walk home. Water is one of the huge challenges in this area. It's a very arid area. People often get water from contaminated streams. and they boil it, which takes fuel, which takes money. Wells, boreholes are the ideal way, but the problem is there's still a fairly high salinity content to the water, so it can be a problem. We installed this state-of-the-art solar well pump to save diesel fuel. It's worked extremely well. We work on the bottom left here. Every community has a water committee, and we make no decisions about whether to purchase water filters or whatever until we've met with them. Again, the Maasai know about elephants, which are a real cramp sometimes. The drainage from this well goes underground, underneath this trough, and then they built two parallel, very sturdy, almost like a trough, so the elephant cannot take its paw and crush down on the pipe. Within the last 6 to 12 months, we have begun installing these water filters in schools. They have a dialysis grade fiber filter, 2 of them. They'll last about 3 years. They cost $200. Most of the kids, and it comes with instruction about how to use them. The kids, instead of using common cups, now all bring a used soda bottle, so they have their own drinking utensil. Bottom left here, where we paid to have some construction done to raise that water tank. Well pump works pretty well. So there are a variety of community projects. Hands-free wash stations. This is called a tippy tap, which you can see on the internet. All it takes is some locally available supplies, a used oil container. You step on the little wood panel, it tilts that. You can wash your hands very effectively, hands-free. We originally had soap hanging down on a little rope with this. We've done away with that because the animals eat the soap. But during the dry season, our nurse Martha, who is a gem of a woman, said that she has more school visits because the kids have more gastroenteric issues. We meet with clinic committees virtually every time we're over there. Martha spends a lot of time on health education. We also have sponsored a number of community health teaching. In this particular one, we provided enough supplies so that every person who attended the workshop could go home with enough supplies to build their own tippy tap. And this is Benedetta, who's head of the sewing center, just showing the people about the reusable menstrual kits. So Days for Girls was founded in 2008. It's now become a mega nonprofit. There are probably close to 1,000 chapters now, of which we're one. They've now reached close to 400,000 girls on a stat I read last week. And basically, these are reusable, soft, absorbent kits that will cost somewhere around $5 for 3 years with no environmental pollution, and they've been extremely well received throughout the world. Catherine was the one, she's a nurse, came to us and said, if you want to help us, we need menstrual supplies. We came back, scratched our head, couldn't figure out what to do until my wife read a little article on Oprah, and within 6 weeks she had flown out to Seattle area, gotten trained. Then we came back, created our own Connecticut chapter. We have over 100 volunteers. It's not only menstrual kits, but an entire educational program that deals with the menstrual cycle, normal physiology, sexually transmitted diseases, how to say no, a little bit of self-defense moves. And people that teach it are certified to teach it. These young ladies had their kits for about 2.5 years. Marianne interviewed them. All the kits were intact. All the kits were in perfect condition. It's now 2.5 years. So this is just the flip chart that we use in some of the teaching. It can be taught by anyone who wants to take a very short online course. So originally when we started out, this was the building where the women were sewing, and there's no electricity. We got enough financial support to be able to create this new structure in the bottom left, which is slated to get electricity within the next few weeks. Teaching really is done in a segregated fashion. This is health teaching. These are a lot of senior elders talking about menstruation, about these kits. This is a very, very remote village. These guys bought 35 kits on the spot at about $5 a piece. The thing that's very interesting, I've done a lot of men's health teaching over the years, and you know, it's interesting, the concerns are all universal. Why doesn't this work right? And how come it's hard for me to pee when I get older? Same everywhere you go. This is just some of the sewing center team. We have provided them with, these are all manual sewing machines to be replaced by electric when the power comes. These are die cut machines that help facilitate cutting of the kits. And these are just a few of our supporters. We also have collected and distributed reading glasses. American Friends of Kenya rents a container every year, and we have now have one of our communities as part of a network that they've created, run by Kenyans. These are just some of the books arriving. This is the teacher's prep room. We hope maybe we can do something about that at some point. OMAC is the prosthetic company. This young man on the left was playing soccer at age 18. He fell. He got a compound comminuted fracture. There just happened to be a doctor's strike at the time. And so he had delayed care, and he eventually ended up with a AK amputation. He also runs a barbershop. Once he got his prosthetic, his life changed. He's now enrolled full-time in an orthopedic hospital training program to do cast application and assist doctors. This young lady sustained a cobra bite of her left hand. Again, there happened to be a doctor's strike at the time. She didn't get care for 24 hours. She had necrotizing fasciitis, and we are in the process of working toward getting her a functional prosthetic. Unfortunately, they're pretty expensive, but we're working on it. Now, this is a program that we're supporting financially. Josephine Indiris is a college grad, highly articulate woman who runs a program to help educate people and change their attitudes toward traditional female circumcision, which is still done in the areas where we're working. This requires a huge amount of time, money, and energy. But they're doing a lot of wonderful programs. This was an International Day of the Woman in March, sponsored by Mukogodo. These are some of the Sambaru dancers doing interpretive dance, talking about FGM, talking about sexually transmitted diseases. Our ladies did a little skit on menstruation. But the key to any kind of a gathering that you have, you've got to have the senior elder on board and willing to talk it up, otherwise it won't work. On this day, they had between 75 and 100 women underwent cervical cancer screening and breast exams in the clinic that's run by Martha. So they will generate esprit de corps, generate relationships playing tag rugby. They have weekend camps that are co-ed, that are well structured. This is tag team rugby. Cool thing about this is when the ladies make a goal, they get 3 points. When the boys make a goal, they only get 1. And if it's a tie, it's the young lady that has to score the point. So Quinnipiac University, and we've been working for several years now. David Hill is a professor of global health, both at the undergrad and medical school. And he's been over there with his spouse and us for 3 or 4 times now. This is the first medical student, Kristen, who just came back, having worked on the Mukogodo Girls Empowerment Program. Now, before we do that, I just want to make one comment. When we were there a few weeks ago, Josephine showed a graphic PowerPoint to segregated groups of men and women showing the actual procedure of female circumcision, all the way from little kids all the way up to teenagers. And many of the women in the room had been circumcised, but it happened so long ago they didn't remember much of it. The men had never seen this. There were tears, people walked out, people were visibly upset. But what the men did at the end, they said, we don't want this to happen to our daughters and women anymore. So we're going to make a change. So on November 18th, coming up, they're going to have what's called a blessing ceremony where they undo the curse on women who have not been circumcised. Now, if this really does come to pass, this is a huge, fundamental grassroots cultural shift that could really change the lives of men, women, and families. This program is about a $30,000 a year program. It's not a cheap program. So, Nanyuki District Hospital is one of 47 in Kenya. This is a typical post-op surgical ward. The operating room, Dr. Shulam and I have been through on a number of occasions, and it's equipped to be able to do virtually all open surgery, and certainly you could do endoscopy if we brought in the equipment. So why establish a program? Well, there's a profound need. There is no urological care in this city of 50,000, and furthermore, in the area of about 450,000. There is no urology. General surgeons can do prostate biopsies, perineal. They can do orchiectomies. They sometimes do an open prostatectomy. But basically, everything is referred out. We were approached by the county health department about the possibility of creating a joint initiative. We have well-established relationships now. All the people that you saw earlier, I know on a first-name basis and have been working with for 3 years. There's an opportunity. Dr. Shulam is very excited about the possibility of creating programs at multiple levels, maybe even at the medical school with podcasts in Nairobi. We already have the very basics covered through Kenyan Healthcare Initiatives, and now we're going to have a presence in the center. So there is an opportunity for multi-level involvement. There are opportunities for teaching and learning. Our residents will be subjected to things that they probably are not going to see here. And the main thing I want them all to go home with is how to do a decent open prostatectomy, because that's an important operation to know how to do. It's important to give back, to be a global change maker. So this is the outside of the operating room. Inside, they have a major OR, a minor, a recovery room. The boss man was there with me in the spring. This was the signing of the Memorandum of Understanding. This is Don McGoy, who is the current acting Minister of Health for Laikipia County. He will step down once they have a new government in place, but he's still going to be within the department, but not as the head. So we had a little PR here. And then after this was all done, Dr. Shulam and I really beat the bushes looking for suitable housing for the staff and for the residents. And this is what we came up with. This is where the attendings are going to stay. And this is where the residents are going to stay, depending upon their ability. And yeah, there are a few lions there. So I just want to bring everybody up to date in the couple minutes that are left. Originally, it was just going to be a GU department initiative, and then Dr. Shulam and I got talking, said, gee, you know, it would really be nice to have an anesthesia team as well. So I came back, and during the summer, I've had a number of meetings with anesthesia department. They're very excited. They're not quite as far along as we are in that they don't have their memorandum of understanding put together yet. But we just had a perfect storm of unfortunate circumstances. One, there is a national nurses strike, which is in its 120th day, which has shut down all public facilities in Kenya. Nanyuki Hospital is a public facility, so the hospital is currently basically shut down. Secondly, the anesthesia department still has to put the finishing touches on their memorandum of understanding. And thirdly, if any of you followed the politics in Kenya at this point, on the 8th of August, there was a national election. The spread between the incumbent and the opposition leader was almost 10 points. So everybody thought, gee, we're going to have a peaceful election and, you know, move ahead. The Supreme Court of Kenya, and this is the first time this has ever happened in Africa, overturned the election, saying that it was not held within the parameters of the Constitution. The International Election Committee apparently signed off on it as being reasonably corruption-free. So the current president, Kenyatta, is still acting chief, elected, but the election was overturned. So on the 16th, they were supposed to have a new election. And then it was moved back to the 26th of October, which just happens to be the president's birthday, Kenyatta's birthday. And yesterday, I think it was yesterday, the day before, Raila Odinga said, I'm not going to participate in this rerun. So Kenya could be headed for some further political turmoil. We really laid the groundwork for this initiative. Dr. Schulman and I have met a number of times. We've met with other people. And I think we have things pretty well in line so that when these various outside factors are adjudicated, we should be able to go ahead. And I'm hoping that perhaps after the new year, we will be in a position to start. The program is envisioned to start slowly, maybe 6 to 10 cases for the first week. Dr. Shulam is hoping for 1 week, 3 times a year. The first visit will be a getting to know you, sort of understanding how the hospital works, a little bit of cross-cultural sensitivity training and so forth. The people over there are very bright. They're very cordial. I think the facility is adequate enough that we should be able to do a pretty full gamut of open surgery. Dr. Shulam hopes that he might be able to get Storts to provide loaner instruments during the time when the team is there, so they could do intraoperative endoscopies. Patient loads will be generated through the primary healthcare clinics. There's lots of things to do over there, including fistula repairs. All stone surgery is referred out. I mean, there are lots and lots of good things to do. But when I went through a log for a year, I saw very, very little in the way of GU. A surprising number of torsions, some worchiopexies, 2 prostate biopsies, a couple of open prostates done by general surgery. I'm happy to answer questions in the last couple of minutes. Anybody has any thoughts or ideas or questions they'd like to ask?
Do you imagine that if, when the program starts, whatever attending is going there, will they know ahead of time what surgeries they'll be trying to do when they arrive?
Right. The agreement with the health department, Don McGoy and the guys, and one of those fellows is actually the medical director of the hospital. And I've met with multiple hospital administrators. They will create a list ahead of time. And I would think once this gets going that we should be able to increase the volume, or maybe some people want to stay longer than a week. But, you know, you'll have 5 working days of surgery. They have CME grand rounds every Thursday, so that's going to be a formal teaching opportunity. And there's certainly be an opportunity to do teaching on ward rounds and so forth. But yes, that will be predetermined. And I would assume probably they would be not only predetermined, they'd be screened, they'd have a physical exam, they would, and we would sign the consent forms and so forth. Yes.
Firstly, I want to say thank you so much for everything you've done this initiative. I think this is really interesting and great. And I think I speak for all the residents when we say we're really excited about this possibility, despite the turmoil and whatever's going on, like in the near short term. But is there anything that we can do to help you? Because that you and Dr. Shulam have been taking so much point on this and have just done so much. I feel like sometimes we don't really know what's going on. So that summary was fantastic. Is there anything that we can do kind of at our level to help you move forward this and get this really kind of on the ground over there?
Well, that's a good question. We have addressed the issues of finance already. I applied for and got a grant for 2017 for house staff coverage through the medical staff grant, but that may be rescinded because we're not going to get to use it this year. So I'll reapply this month, and that's $3,000. That would be helpful. Dr. Shulam and I, as well as some other faculty members here, have gone to the support group that provides financial independent outside support to the department, and we did get a commitment of $20,000 from one donor. So that really will cover us for the first year. We think that it should be around $15,000 to $20,000 a year to get a team over there for 3 times, staying in a very, very nice Caribbean style, well, except for the residents. It's a nice facility. It's got a pool. It's got a gym. It's a nice spot.
It's okay. I think the resident place had free chips, so it's okay.
It's hard to know. Certainly, as we move forward, we will want feedback. I've tried to look at expectations as we've gone along, so they're realistic. I mean, it would be wrong to go there and do 20 cases the first time, because one, you're not going to get through 20 cases, and secondly, there's a lot of other stuff out there in the way of teaching that's equally important besides hands-on surgery. The time difference between this grand rounds and Nairobi is 7 to 8 hours, depending on daylight. And there's no reason why this could not be a podcast to the medical school in Nairobi. And they have all the usuals. They have Da Vinci's and everything in Nairobi that you would want. And where I work, we have virtually nothing, truly. Fundraising, well, that's not something that I think you guys really have time to do. But networking, is very, very key in trying to, move any kind of initiative forward.
Perfect. Thank you so much.
Dr. Stroup, I just have one more question. I think this is awesome. But what year, how do you envision the resident's role in the community, and what type of level of responsibility, as well as what year of level resident do you kind of envision to take advantage of this amazing opportunity?
Since this is going to be primarily your role will be not dissimilar to what you were if you were, say, a PGY3 doing open surgery. So, I envision this as an opportunity to really acquire surgical skills as well as teach to other house officers. There are something like 85 trainees at this district hospital in various disciplines. So it isn't, there are lots of people with little white jackets walking around. I mean, it's not like we would be in a vacuum by any means. So I think there is a lot of opportunity for residents to acquire certain skill sets. And no, I think that vesicovaginal fistulas and open prostates are probably two areas that where we're going to be able to make a real impact. Hey, thanks a lot.